So today I was asked to come and talk about, when Emma called me, she says, talk about resilience and stuff. I'm like, okay, big topic. And then I met with Devin and Emma a few weeks ago, and I realized I always knew it was a huge topic, but I thought, okay, this is really big, and I had to figure out a way to get our heads wrapped around it. And so I really want to note the question mark after the word post. All right, I don't think we're through anything, and a lot of the things I'm talking about today have been going on for a while, pre-pandemic. First of all, I thought I should show you that when I was sitting in my office at home working on this is what came right by my window. Isn't that cool? That little bear, I know, this has not very much to do with resilience, except I love living in Vermont. And this bear actually climbed up, it's wet because it was raining, those are the drops. It actually climbed up our apple trees and dangled off the top like a monkey and ate everything. So I just thought I'd share anyway. So I live up closer to Burlington in somewhat of a rural spot where I get to have bears come in my yard. I think that's pretty cool. My daughter was freaked out, but she just has to get over that. So here's what we're going over today, all right? The top two are where we're going to start. We're going to look at some data, because I tend to be a bit of a data-based gal. It helps me understand the extent of an issue and where to jump in. We're going to look at the state of union of burnout, mental health concerns. We're going to look at its impact on a variety of things. And then we're going to look at a way to understand this issue. Developmental psychologists like to think in models. And so I can't help myself but think that way, because it gives me many ways to jump in. So I'm going to do that today. And then I'm going to put you to work. It's not going to be that hard, all right? But I'm going to have you do some brainstorming about how we could apply this to your organizations. And then I want to leave you with some thoughts on how to adopt a resilient orientation. All right, so I want to take a moment and just comment on mental health and physical health. It's a dichotomy that's out there that's completely inaccurate. Probably you all agree with me on that, but I thought I would take a moment and just point out some of the differences and similarities just to get us going. I clearly come from a mental health background, but I work in a physical health environment, and so for me this has been a really important question to look at. So some differences. All right, you ready? You all get depicted in hospitals much better in shows, right? I mean, really, this is how I'm depicted. Hanging out with mobsters or having one of my clients follow me on vacation. That's totally not fair. And then, honestly, you guys have better rides in hospitals, all right? Nobody says, put Cath in the helicopter and fly her someplace because somebody's having a hard time. Right? And I'm not making fun of this. I actually am really glad you have these rides, and I've had to use these rides, unfortunately, and I'm really thankful they're there. And this is my Subaru. That's my ride. And incidentally, the heat's stuck on and the air conditioner doesn't work, which is great in February, not so good in July. And then the next comment, which I think is huge, which I think is part of the issue that contributes to some of the problems we're having today, is in physical health, or in medical centers, we have big, visible facilities, which is what you want, right? You want people to know where to go. You want to know, you get on the highway and you're like, I need to go to a hospital. There's an H that tells you where to go. There is nothing like that in my world, okay? And I'm not saying one is better than the other. I'm not trying to pit anything against each other here. I'm just making a point that when we've had big facilities in the mental health world, and on the top you see the Brandon School, which many of you may recall was a training center for people with intellectual and developmental disabilities. I actually had a foster brother from there when I was a kid. I am, in fact, that old, all right? And we all are probably well aware that it was not a great way to treat people. And then below is a very old picture from the state hospital in Waterbury, where clearly we had thousands of people housed who had mental health conditions and other things that now we really understand very differently. So there's a good reason why we don't put people in big, huge facilities, right? It doesn't work well. But the problem is that it has the unintended consequences of making these services invisible. So you don't know where. You know, a lot of the agencies that I work with are very proud of saying, I bet you don't know, but we've got 40 buildings in your community. People go, really? Where? The point is that we want to protect people's privacy and we want to avoid the ill consequences of stigma. And we don't, when I would drive kids around, one of my first jobs in the field was working in a psychiatric hospital for kids out in Colorado, and I would pick them up on a van. And the van could not say the Cleo Wallace Center, right? Because it's just not what you do. So there I was driving around a bunch of kids who are what we used to call at the time prodromal. I could have used some attention to help me with those kids, but we didn't do that because of the ill consequences. Oh, the other difference I wanted to point out is that people tend to use medical care more, right? We know that, and this is from 2020, about 83% of people have seen some sort of medical doctor in the past year. In contrast, maybe about 20% of people in the same year have seen any mental health professional. And when I say any, that could be anybody that claims to be a mental health professional. It doesn't have to be a psychologist like me. And that'll become more meaningful in a moment when we talk about the incidence of these issues in our country right now. But I want to point out we have a lot of similarities. So the dichotomy that tends to roll around when we're advocating, this is my opinion, advocating for funds, advocating for attention, actually works against us because there is so much in common. There has been profound changes, as you all know, in our payment models and healthcare policy that have definitely infiltrated down to the level of practice for all healthcare providers, and here I'm talking about everybody in health, which includes mental health. It's added to the administrative burden, which I know you all have heard of. It's staff shortages clearly is something we're all tackling now. It's huge. All of us feel underfunded. I think all of us would say we feel chronically underfunded. And there's a lot of misunderstanding, I think, by the public and sometimes by policymakers of what it's like to try to work within the system. And so this poses for everyone a lot of ethical and moral dilemmas, which is something we used to think about only with regard to war veterans, and I'm going to talk a little bit more about that in a minute, but it's something we're seeing more of in our healthcare providers across both sectors, and there's more, too, from there. So I guess I'm going to focus today as I talk on these similarities. So when I say health today, I mean everybody. When I say physicians, a lot of the data is about physicians. We don't have a lot of data about community mental health providers or community respite providers, okay? But when I'm talking today, I want us to think about everyone. So we all know a healthy body, healthy mind is just a happy human. And I know when I sit with kids and their families, that's one of the things I talk about. I'm like, sure, we can give you a medicine to make you feel better, but how about we start by doing a little walking and running, and then we jog up the hill to prove a point. So I wear good shoes to work. What is mental health? And I remember I asked a group this a while ago, and they said, oh, well, mental health means you don't have schizophrenia. And I'm like, well, that's a bit of a low bar, I'm not quite sure. And the ironic thing is a lot of people, I've worked with some folks that really deal with really tough mental health conditions, like tough, that really limit their ability to work, go to school, be with friends, be with their family, be independent. And in some days, they're healthier, more mentally healthy than some of the other people I meet. And that actually shocks a lot of people, and I know you all know this. But so I like to point out that poor mental health and mental illness is just not the same. So I just thought I'd show this. Let's hope this works. Let's see what the World Health Organization has to say. It's just a quick film about mental health.
We all have mental health. It is just as important as physical health. It is not only about mental illness or mental disorders. This is just one part of a bigger picture. It's best to think about mental health as being on a continuum, rather than people being either mentally ill or mentally well. We are all on the continuum, and we move up and down according to factors such as our genetic makeup and upbringing, our life circumstances, and the stresses we are under. At one end of the continuum, we have mental disorders, like depression or anxiety. And at the other end, we have states of positive mental health, when we're thriving, content, and fulfilled. The aim of mental health interventions is to move people up the continuum, so that they're able to reach their full potential and live satisfying lives. The World Health Organization describes mental health as a state of well-being in which every individual realizes his or her own potential, can cope with the normal stresses of life, can work productively and fruitfully, and is able to make a contribution to his or her community. Being mentally healthy means being resilient and able to cope with difficult times, feeling in control, being confident, feeling good about yourself, managing and expressing your emotions, building and maintaining good relationships. We all experience periods when we feel stressed, worried, anxious, sad, afraid, or angry. These are all normal emotions. However, when these emotions become severe enough that it interferes with a person's ability to function daily, and these feelings become persistent over time, then it can develop into a mental health problem. There are many different types of mental disorders. When left untreated, mental disorders can be chronic and long-lasting, and are associated with increased disability. They significantly have an impact on daily functioning and frequently interfere with family, social, and work responsibilities. Fortunately, there are effective treatments and evidence-based interventions available that aim to help individuals understand and cope with symptoms of mental illness. However, very few people with mental disorders access existing treatment services. This may be due to barriers such as the stigma attached to seeking help, the lack of understanding of mental health problems, uncertainty of how to get help, or the fear of disclosing mental health problems. Research shows that stigma remains one of the biggest factors preventing people from seeking help early for their mental health problems and getting the appropriate support they need. It is important to acknowledge that we all have mental health and have a personal responsibility to learn how we can improve and maintain our well-being in order to lead meaningful and satisfying lives.
All right, so we had to, let me just get myself to the right place here. Here we go. So just to go over a couple of data points, and I don't mean to data you to death, but I think it's important, and then I am going to get to data specific to healthcare, okay? So this is an old estimate. This is prior to the pandemic hitting. At that time, 1 in 5 adults will experience a diagnosable mental health condition in any given year. I would say that 100% of us experience symptoms of anxiety or depression at some point in our life. If you haven't, I'm concerned about you. Pay attention. You know, being mentally healthy doesn't mean you never feel that way. Being mentally healthy, as they said in the video, means you know how to cope with those things. So it's amazingly common, all right? And during the pandemic, some estimates I saw were upwards of 40% of adults were experiencing mental health conditions of anxiety and depression. I think it really varied, and it'll be interesting to see what happens as the data come out. In 2021, in this particular study from Mindshare, 76% of the people polled were endorsing at least one symptom of a mental health condition, with the highest 3 being burnout, anxiety, and depression. And then what's interesting is a third of these people were experiencing these symptoms for 5 to 12 months, which is a pretty long time to live with those things. And then a lot of people will not seek treatment. About 80% of people will not seek support for these conditions. That's concerning, because we know that more than 80% of employees, in this other study I read, actually improved their productivity once they got support. All right, so stigma's a problem. We want people to get the support they need, because you'll see in a moment there's clear impacts on people's ability to do their jobs, and in our worlds, to care for the people who come to seek support from us. So of healthcare workers, and you've been seeing this, I'm sure, 3/4 of them are reporting exhaustion and burnout, and that's in 2020. And then my colleague, Simone Ruschemeyer, for those of you who know her, sent me the Twitter feed last night, which it's in the news all the time. How many of you have been seeing this data about burnout and stress and anxiety and depression in healthcare workers? The other thing I want to point out is I went ahead and consolidated some. I'll talk you through this busy slide. So what you see here, the yellow line, and just look at the direction of the lines. The yellow line is professional fulfillment. On the bottom, you see the year, and on the other axis, you see the percent, and the yellow line is going down. Okay, professional fulfillment's decreasing, no shocker. The white line is one symptom of burnout, which you can see jumped in 2021. The red line is a measure of just overall satisfaction with my work. And then the orange line, and this is amongst physicians, okay? The orange line is ratings of depression. So, burnout's going up, depression's going up. Amongst people, we need to show up at work and feel good to take care of us, right? If we look at subspecialties, the top areas that we see people really struggling is in critical care. That's probably not shocking to you. And you see rheumatology, infectious diseases, urology. And then on the right, you see on the top that a large percentage of people were saying, this was starting before the pandemic, gang. All right, this is not new news. The pandemic just really shed light on it and probably made it worse. And you see it's more common in women, the second little arc graph down below. And you see then on the bottom right that 47% are saying it's having a real severe impact on my functioning. This data came from a group that it's a private group, so I'm a little skeptical, but I still thought I would share it because I found it a little compelling. They polled 1,000 healthcare workers, not just physicians, all right? And of this polling of 1,000 healthcare workers, and this was done this summer, all right, this past summer, for like a month, 1 in 7 reported using alcohol or controlled substance at work. 1 in 5 consumed alcohol or controlled substances multiple times per day. And then 49% of them said they were at their breaking point due to stress and trauma. So even if it's a really bad study and they had bad sampling practices, which I was not able to pick apart, that's kind of bummer news, don't you think? I mean, that's not good. So, yeah. So I'm not trying to bum us all out. We're going to go through here some of the things we're seeing, and then we're going to talk about what to do about it, all right? So hang in there. So I think you all know burnout is caused by high job demands and just insufficient resources, right? That's sort of a no-brainer. And when we pick it apart, we see specifics around high job demands from just a ton of work, not enough time, the administrative burden that we mentioned before, workflow problems and interruptions. You can read the list there. But I want to point out some of the main bullets that are really, I think, coming to the surface, particularly for physicians, is this notion of developing some sort of a good work-life balance and this moral dilemma. Because people are being faced with the problem, and we'll talk more about it in a minute, of wanting to provide care but not being able to because of systemic constraints that limit them, which is directly impacting their own burnout and satisfaction with their jobs. Most of us have in this room, I think, and you can let me know later if I'm wrong, and I'll apologize in person. I think most of us have the luxury of choosing our work because we find fulfillment in it. And so and we don't mind working long hours. We choose to work long hours because it's fulfilling to us. So if you take that away, it just makes it harder for you to find the resilience in your work. So why do we care? All right, you could just say, suck it up and deal. I'll hire somebody else. I work with kids, so sorry, I use words like suck it up. All right. This is old, right? This is from 2015. The cost of mental illness will be more than cancer, diabetes, and respiratory illnesses put together. All right, that's kind of a lot, and my guess is that it's more now. This is a number I can't understand because it's just so big. This is from the World Health Organization, who's estimating that the global economy will lose $1 trillion per year due to anxiety and depression alone. You know, I'm paying a college tuition. I can't even understand that number. It's just too large. And then when you think about turnover, like when people get burned out, dissatisfied at their jobs, and if they can, they leave, right? So generally, it takes 6 to 8 months of someone's annual salary, the cost of their annual salary to replace that person. So for a person that earns $60,000 a year, you're talking about it costing about $35,000 to $40,000 to replace them and train them and get them on board. So what about physicians? So the estimate per year for the cost to us, right, is between 2.6 and 6.3. That's a wide gap. All right, there's some variability in the literature about what it is, but still large number. Another way to look at it to drive it home is it costs about $7,800 per physician. So in my pragmatic mind, I'm like, okay, that's $700-800. Let's spend it on something else to try to help people feel better. I'm not dumb. I know that's not how it works. There's not, like, you can't just take it out of one account and put it in another. But it's an interesting concept to think about. What would you do with that money if you were able to use it to really help support your staff? And this busy slide, the point of it is that for physicians, about 3/4 of them are saying they've had a reduction in income. All right? We're losing private practices, which we need, right? They're closing. They can't keep up. And that's going to cause a shortfall of physicians, which is a problem because we need them, right, as the years go on. And I would say this same problem is extending across our healthcare sector, and it's concerning to me because there's a lot of people that we serve outside of institutions, because we know that's good care, who aren't receiving care and will increasingly not receive care. And I wanted to make a comment about moral injury. You know, as I was reading about this, I thought, oh, I can sort of relate to that, okay? It's the idea that, and this is part of the whole picture, I alluded to it a moment ago, it's the idea that you feel like you are failing to prevent someone's suffering, whether you mean to or you're just not able to, you're failing to prevent it, and you feel betrayed by the system within which you work. And what I've been increasingly reading is that a lot of people working within healthcare are experiencing this. And the problem is that when moral injury becomes really significant, the information about how best to treat it is a little inconclusive at this point. And that's a little different than burnout, which we tend to throw that term around a lot, which is people feeling tired, ineffective, and just kind of removed or depersonalized or disconnected from their work. So what's interesting is if you reflect on some of the staff that you know, I wonder if, as you think about some of the conversations you've had with them, if maybe you've seen some indications of moral injury amidst the conversations around burnout. So sources of moral injury you're going to see look similar, all right, as those for burnout. You see too many bureaucratic tasks, all right, too many hours spent at work, that's the work-life balance, lack of respect from other staff, insufficient compensation, and lack of control and autonomy. And one of the biggest things I find amongst people that I meet is they want to have some control and autonomy over their life, whether you're the person practicing or the person sitting receiving the care, whatever care that is. So, let me play this for you. This is from King's College, where they had it's not very long, little background on moral injury.
Moral injury. What is it all about? What is moral injury? Moral injury refers to the intense psychological distress which can follow actions or the lack of them, which strongly clash with someone's moral or ethical code. Whilst moral injuries are not mental illnesses, they can cause strong feelings of shame, guilt, or anger. The history of moral injury. Moral injury is not new. It was first written about possibly as far back as the ancient Greeks. Since that time, there is continued evidence of its impact on military personnel up until the end of the Vietnam War in 1975, and of course in subsequent conflicts as well. Moral injury does not just affect the armed forces. Whilst the term moral injury is often linked to military service, it can affect many other occupational groups, including media professionals, social workers, healthcare staff, vets, lawyers, and aid workers, to name but a few. What causes a moral injury? Moral injuries may occur in three ways. Firstly, when an individual or someone else has done something which they should not have done. These are known as acts of commission. Secondly, when an individual or someone else should have done something but they did not. These are known as acts of omission. Thirdly, when an individual feels betrayed by others, often by a higher authority. The spectrum of psychological difficulties. Moral injuries occur along a spectrum. Some people don't seem to be affected much at all. Others experience short-term distress with no substantial lasting impact. However, when the if-onlys and what-ifs do not go away, but become more intense than a moral injury has developed, some of which develop into a formal mental health disorder. What is the impact of moral injury on mental health? Research carried out by King's College London shows that morally injured people are vulnerable to developing other mental health disorders, including PTSD and depression, and experiencing suicidal thoughts. What are the risk factors for moral injury? Certain situations make moral injuries more likely. Events involving vulnerable people, such as children or injured colleagues. People feeling unprepared for the emotional consequences of their role. A lack of social support, or people who experience traumatic and morally challenging situations at the same time. Moral injury acts as a barrier to recovery. Unfortunately, people with moral injuries often feel ashamed, guilty, or angry, which can make them very reluctant to talk about their difficulties with anyone, including clinicians. They may worry what others will think of them, or even get in trouble with the law. However, because they don't speak about their experiences, they can't make sense of them, and so they don't get better. Treatment for moral injury-related ill health. Currently, there's no clearly defined way to treat moral injuries. Clinicians therefore find it difficult to provide support to those who experience them. Some psychotherapies may also make moral injuries worse. Currently, the most effective way to provide support or treatment for moral injuries is to help people make sense of what has happened to them. Conclusions. To sum up, moral injury is not new. It's often linked to the military, but affects people from all walks of life. It's not an illness, but it can have a serious impact on people's lives and lead to a range of mental health disorders. If someone has a moral injury, they should be helped to make sense of their experience or be encouraged to seek professional help.
So, this is the total bummer slide to sum up kind of what we've been through, all right, just to be honest, okay? And the bottom line is, with burnout, moral injury, and and the increase of mental health conditions amongst all of our healthcare providers, right? We're seeing an increased problem in relationships that have fallen apart, whether it's personally or amongst colleagues. We're seeing increases of substance use. We're seeing increases of depression. There was mention of the increase in the incidence of suicide. But it also directly, as you obviously know, affects the care we provide. So the end user, if you will, is also dramatically impacted by this because we don't have enough people, or the people aren't able to do the work that they would like to do. So out in the world beyond healthcare, they tend to lump the kinds of effects of this into these categories. And I want you to think about what you've seen the most, and I'm going to ask you in a moment, so that's your prep, okay? So one is they see reduced work output and productivity. 2, unsafe work conditions, so maybe increased med errors or increased accidents. 3, poor morale, workplace, and increased turnover. 4, people not showing up to work. And 5, people showing up in body but not entirely in mind. I want to move on now to how we think about this, okay? And as I mentioned before, I was trained as a developmentalist. I think in models and structures, and so that's where I'm going to start. Do any of you know who Yuri Bronfenbrenner is? Anybody? I'll give you $5. I actually don't have a $5 bill, but okay. So Yuri Bronfenbrenner was this fun guy, well, I say fun, and I'll tell you why in a minute, out of Cornell, who basically said, you know what? Remember, we're talking development here. Kids don't just grow up as little people into big people. They grow up and their development results from, you're going to be like, no duh, he got awards for this, but anyway, they grow up in the context of a broader system. So it's not fair to just intervene with a kid alone without thinking about how to intervene with their family, thinking about how to intervene in their school. Do you see the concentric circles going out? Maybe in their neighborhoods, maybe in the broader policy, right? Because all of those things directly impact a kid's development. You see where I'm going with this? All right. And the arrow on the bottom is that this whole sucker moves through time. So it's impacted by historical events, pandemic, wars, all right? which affects all levels of this system. Now, funny little story about him. He's sort of a big deal in my world, and he came to speak at UVM when I was finishing my PhD, and because I was the oldest student there, yes, I was, and I had the cleanest car, I was asked to pick him up from the airport to come and give his talk in the morning. And I was really nervous, because everybody's making such a big deal. I'm like, ooh, anyway. So I went and got him, and I thought, oh my gosh, it was one of those frigid winter days. And he was older. I was sure he was going to fall down and break a hip. I don't know what. And my advisor had told me, if you don't get him here, that's it. I'm like, okay, I got it. So I picked him up, and he came out. He hopped in the car, and he goes, what do you say we go skiing? And immediately, I just loved the guy. Yeah. And this model has really helped me because a lot of the times, and a lot of the interventions we talk about are at the person level. So Cath, so you're feeling moral injury and burned out at work. Let me help you figure out how to do that. Let's do some yoga. Let's do a little mindfulness. All good stuff, right? But that actually is not going to solve the problem. Wouldn't you agree? It might help me deal in the moment, but it's not going to solve the broader issues that are causing this to begin with. So, unfortunately, the National Academies of Science also agree with that view. They've got to know something, right? That you want to think about the person, but you also want to think about their teams and their immediate leaders. You want to think about your local healthcare system, whether it's a building or a network of buildings, and you want to think about the broader industry and the societal influences on what's going on. The good news is that this gives us a lot of places to jump in. Does that make sense? I am an internal optimist, or I would not be in the field I'm in. I want to be clear. So you could look at this as we're hosed. There's nothing we can do about policy, how things are being run, but I actually choose to believe that we can. So we're going to just take a walk through this a little bit today. All right, and do you know this guy? Surgeon General, second time around, what a glutton for punishment. Could you imagine his job? I actually have a lot of respect for him. I think he's done some interesting work. He had that whole initiative around, not that he's wanting my respect. I have to say he hasn't called me and said, thanks, Cath, I'm really glad you respect me. But he's done a lot of interesting work around the impact of depression on men's health and beyond. Anyways, and have all of you heard about this priority that he's put out? This has become a national priority for him about healthcare worker. So let me play this for you so you know, and I'm not just making it up.
From the moment we come into this world to the times throughout our lives when we are hurt or sick or need help, health workers are there for us. They are the core of our healthcare system. It's hard to imagine where we'd be without them. But the truth is, they are now struggling with burnout to the point of crisis. Even before the COVID-19 pandemic, health workers faced major challenges. 54% of doctors and nurses were already experiencing burnout. With the pandemic, things have gotten worse. Health workers have sacrificed so much during these last few years, sometimes even their own lives. More than 50% of public health workers have reported symptoms of at least one mental health condition, such as depression and anxiety. 8 of 10 health workers have experienced workplace violence, and 66% of nurses have considered resigning. Health workers are leaving their jobs in large numbers. We're looking at a future without enough doctors, nurses, and other critical health workers. That puts our entire healthcare system at risk, and it makes it harder for patients to get care when they need it, not just for COVID, but for all our health needs. We must take action. Join me in calling for the urgent changes our health workers need to thrive. Healthcare systems, health insurance companies, and government must prioritize health worker well-being. This means increasing access to mental health services, reducing workplace burdens to prioritize time with patients, and protecting the health and safety of all health workers. We can all help by being kind to our health workers, recognizing the stress that they're under, and by taking care of our health to the best of our ability. Together, let's prioritize the well-being of health workers. It's time for us to take care of those who have always been there for us.
Okay, so I would encourage, if you have a chance, the resources available through that particular paper are helpful, and it links back to a lot of applied studies done through the Mayo Clinic that could be helpful in terms of direction, and I'm going to go through a few today. And you're going to see they think about this more systemic approach to addressing this issue. So in his particular, or his department, I should say, paper, they talked about focusing on 5 different areas of promoting healthcare worker well-being. Okay, one is to make sure they're safe, make sure they have the equipment they need, make sure they feel valued and respected at whatever position they're at. And I know, honestly, I know that you all are trying to do this, all right? It's an interesting advocacy agenda in my perspective. The second is, as much as we can, we want to reduce administrative burdens. You've all heard the ratio of 2 hours of work to every hour of clinical work. And it's just unbelievable. And I read one article about a physician who was saying that's when a lot of my errors occur, and I order tests that I don't need and other things beyond that, making care really expensive. So there's something about all of our efforts to reform healthcare that's kind of going the wrong way in terms of administrative burden. We want to promote access to mental health care, which means having mental health care, right? It means having places we can call and people we can bring in at hours that work for the various people who need that care. And I will say right now in this country, if you are younger, it's really hard to get mental health care. If you're an adult right now, it's a little bit easier. But I would add to this to think more broadly, and I'm going to show you at the end, to think a little more broadly about support for mental health care and what that could look like. And we want to invest in our workforce, make it so that people want to go to school to be a healthcare provider. Invest in their ongoing training. I know that in my field, I had several people that worked with me in sort of bachelor level positions who decided to go back to school for their master's because some of the COVID relief funds started to pay for some of their tuition. That's huge. And they're now working under my license providing care. So while it's not much in the scale of what you all do, we're able to care for an additional, 40 kids. I think that's pretty cool. And then this last one is huge, to build a culture that supports well-being. And we're going to talk more about that in a minute. But there's a piece from the pandemic that was lost, which was connection and communication and attachment to our coworkers in a healthy way that we have to somehow bring back. And amongst healthcare providers, they sort of have the suck it up, I'll work long hours culture, and now it's working against them. And that's something that would be good to work on and change. And I know at University of Vermont Medical Center, they're actually working on that with some of their trainees now. They have some groups going for them currently that they're considering. I just heard the other day, I don't know if it's true, so don't quote me, making them mandatory for all medical students to really work on their own self-care. We'll see. If you think about the ecology of the workplace on the left, all right, there's these drivers that impact whether or not people feel burned out, okay? We have their workload and their job demands on the top. We see a person's feeling of control and equity in their positions. We see in the blue a good balance of their work and life. A lot of people really sacrifice their home lives. In my world, people would work unbelievably long shifts in residential programs. I know you had that in hospitals too, to make sure people are cared for, which meant they're sacrificing their families. Making sure there's good social support within the community, finding meaning in their work. That's what drives a lot of people to this work, all right? Having an organizational culture and values that matches and is borne out. It's not just a mission statement that sounds good. It actually is in practice, and that's assessed over time. And having efficient and available resources. And what we know is if you don't have enough of those, you have burnout. And if you do have enough, you have engagement. And now you can all go, duh. But I think sometimes if you can think about things as pieces, it's another way that you can jump in to try to affect some change. So now let's talk a little bit about this, and then I'm going to ask you for some ideas, okay? On the outer sector here, we have our national and state regulations. I know that some of you are probably steeped in various healthcare reform, federal and beyond initiatives that have absolutely affected your workflows and administrative burdens on the ground. Right now, the state is reconsidering sort of all payer 2.0 and different types of payer mixes, and who knows what that's going to do. I know a lot of good minds are thinking about it, but that's happening. Within your buildings, facilities, networks that you have more direct control over, control is a loose term, think about the policies and practices you have in place and how are they set up to really impact someone's well-being. And then you can then distill down to your local teams or your local units and look at how is it working there? Are we building up those different components there? And then finally, we can work with people at the individual level to try to support their own well-being. And before you do anything, you have to start by understanding the issue. So you have to obtain data. You want to make sure you have the right metrics. Are you measuring what you need to know to understand if your efforts to improve well-being are better? And some of the resources I've talked about today have those resources available. And there's also some discussion about should these metrics be included in some of the certification processes hospitals go through. I don't know. I'm just saying it's an interesting concept. You need to be able to collect it. You need to evaluate it. And then ask, did what we did make a difference? It's just a PDSA cycle. This is from the Mayo. This is a project that they ran. I would encourage you to look at it more if you're interested. So their first step was to acknowledge and assess the problem. They did it unit by unit. They looked at the data together. The leadership worked together to try to talk about, not in a punitive way, what's working, what's not, how can we improve this situation. They targeted their interventions to the places where it was needed, and they definitely found improvements as they did that targeted work. It was interesting to read. They did a lot of work around culting community within and external to the building. They talked about things like huddles and other things that you're all familiar with to have people talk to each other. But the whole informal piece that was lost with the pandemic, they put some effort into building that up again. And it made a big difference. They looked at incentives for productivity that were beyond doing more work, all right? Things like getting responses back from patients or their staff or their teams doing better. They worked hard at aligning the values that they said they promoted with what was actually happening on the ground. And they worked hard, and I'm not quite sure how they did this given the constraints that they're existing with, on promoting flexibility in their jobs and work-life integration, trying to do things so that people could work less. On average, doctors work 60 hours a week, much more than the general population, and that is not really conducive to a good work-life balance. Number 8, we'll talk a little bit more at the end today, but they're really going to provide resources. They're working on that around promoting resiliency and self-care. And then finally, at the Mayo, they've done a lot of work on this and they want to share that information. They have a lot of research behind this and how it was effective. And then finally, I'm going to talk about this more in a moment. It's about thinking about this person. It's a shared ownership, all right? I am also responsible for taking care of my own well-being. It's not entirely my I'm my own boss, so it's my fault if I'm not happy anyway. But, my point is when I worked in an organization, it wasn't their job necessarily to take care of me entirely. Part of it's on me. So let's move on. I want to talk about adopting a resilient orientation. I'm going to talk here about that number 8 on that list before about really helping people promote their own well-being and resilience. So, by and large, physicians are generally more resilient than the general population. Yeah, that's what some of the studies I read showed. This was a person that was writing about moral injury, which is why we have to really think about system issues, okay? They come into the field expecting to be giving of others. I would say that's true also of any healthcare provider. And remember, I'm talking about health very broadly here, that people are expecting to have to give more than they might get back. So that points to the need for some of the system thinking about this, which is hard to think about here today, but it's just critical. But with that in mind, I want to talk about resilience and give you some thoughts about it, and then I'll let you have a break, okay? So resilience is the idea that, and I love number 1 here, the idea that something is strained and can somehow go back and retain its size and shape. I think it's kind of an interesting concept that when stress is happening, I don't know about you, but when I'm feeling stressed, I feel compressed. And here we're talking about it as a way of somehow you go back to your original form, you recover, and I would say also learn. And another term I saw was dynamic adaptive capacity. When you're burned out, you're not able to do that as well. A resilient person can handle so much more. Someone said to me a week or so ago, I'm just tired of being resilient, which I get, which is why, I'm right there with you, but which is why we also need the system to beef up, to do some of that work with them. How many of you feel that way? Like enough already? Yeah, I would say so. And you don't have to self-disclose here, but I can guarantee that most of you are also carrying weights at home, weights with your family, weights with your friends, in addition to the important work that you do at your jobs every day. So that said, the good news is that resilience can be trained. And people who are struggling the most or who come into a position with more, shall we say, baggage, people who have more difficult histories, people who have struggled more maybe with mental health conditions or just that general orientation, you can train them on how to be more resilient. So you can target that. And there's domains around how you can train that. You can see in the up top here, we can teach people how to manage emotions. We can teach people how to regulate. We can teach people how to take care of themselves. How many of you got 8 hours of sleep last night? Yeah, how are you feeling today? A little sleepy? The rest of you? What do we know about sleep and anxiety and depression? If you don't sleep, those go up. It's just kind of how it is, all right? I also get it that you all are very busy people and don't feel like you could sleep. So we can teach people how to take care of themselves. Sleep is huge. That's often where I start with the kids I work with. We can work on communication skills. We can teach them how to deal with difficult people because there's a lot of people who are struggling. And we can help them learn how to adapt to change. So you can train that. But I'm going to go back to this graph, and I want to remind you that orange line are ratings of depression amongst physicians. So clearly we still have to work on promoting mental health, right? And providing people with supports for that. And a big problem we're having is that amongst people who identify as needing mental health services, only about 46% of them have received some sort of a service in the past year. So there's just not enough. And if you're a kid, that number is even lower, which is tragic. That's the one that gets me all riled up, so I'll just stuff that right back down in for now. Let's talk about barriers, all right? Because if you know what the barrier is, you can do something about it. Work schedules. I am a terrible therapist after 5 o'clock at night because I start really early. But the reality is, for someone in healthcare, they work different schedules than me. It can make it really hard to get in for traditional care. That's a problem, but it's not one that's not solvable. There's a lot of fear, particularly in the medical profession, of repercussions from colleagues. Your licensing agencies, that if they find out you've had a mental health condition, maybe your license won't be renewed. What's that about? If the percentage of people who have mental illness is growing in your profession, that makes no sense to me, especially when we know, on average, across workers, 80% of people will do better at work once they have treatment. So you just got to help me out. If we have an impending shortage of workers, of health workers, and more of them are leaving the industry, and we know that the percentage of people needing care goes up, why in the world wouldn't we figure out a way to support them rather than having them be afraid of getting treatment? I'll stop. The bullet here at the bottom, we have limited availability of mental health services right now, all right? It's just a fact. For years, people have not gone into this profession because it's not one, remember the slide at the beginning of it being invisible? We try to maintain a low profile, and as a result, we're not attracting a lot of people into the industry. People may not know where to seek help, and they might have limited faith in their ability to actually get that help. That's a bummer, because I actually think there's a lot of things we can do, but the big issue here is stigma. And I was listening to a film. The same day I saw the bear in my yard, by the way, I was honestly on my train or on my bicycle watching a film from a proceedings on physician health, and this person wrote in this question, which is, given the parallel pandemic of physician suicide and the many factors that threaten the licensing and credentialing of physicians who seek mental health care, how can we make national policy changes to truly care for our healthcare providers? There's a broad policy initiative that might be worth thinking about a little bit. And stigma's the problem. It's this idea that if you have a mental illness or a mental health condition, you're subpar. Well, then a lot of us are pretty subpar. So I think that's worth thinking about. And when we look at big industry, these are the employers that employ thousands and thousands of people, the Fortune 500 companies. This particular group, the Business Group on Health, does these massive surveys to understand what they're doing through their healthcare, through their insurance and other healthcare provisions in their companies. And they named their top targets for this coming year. And they said, we're going to work on access, and we need to work on stigma, because we want our people to get what they need, and we want them to come back to work. So we're complicated beings, gang. You probably knew that, all right? We're complicated beings. Our mental health and resilience overlap. We are affected by the community we're in, by the work we do, by who we hang out with, whether or not we're connected to them. It's all in there. And we've all, even if you were an essential worker and you had to go to work every day, your social connections took a hit. And every single person I'm meeting is telling me I'm kind of having to learn how to do this again. And that's it's great you're here today, because it starts actually, I think, with that, is reconnecting with one another and thinking about how to help people do that at your work. So here's some steps to think about, or not. You can do what you want. First of all, study your ecology, for lack of a better term. Consider using data points to look at that. Look beyond the level of the individual. If you only look at the individual, you end up sort of inadvertently blaming them for what's happening to them, and that's not what we want. You want to break the silence and think about stigma and how policies or practices within your organizations might actually be causing stigma to be perpetuated. You might think about ways to support affordable access to care, whatever that care is. And I'm going to give you some ideas in a minute, because it may not just be coming to see me, because I fall asleep at 5:30, that's a problem, right? It could be a lot of other things. And then really focusing on building this culture of well-being amidst everything else you're doing. But it sounds like we've got to figure that out, or we're going to be in a world of hurt in a lot of ways, because we're not going to have people to come to work. So this is just a few of the things that I talk about when people are thinking about supports for wellness and mental health. All right, one is your EAP, what's provided through your health insurance at your building. Sometimes EAPs will come in and do work. A lot of people don't like that, because then people know, stigma, right? But that's an access. Community providers are a thing, right? Private organizations and beyond, sometimes that works for people. Sometimes individual therapy is actually not the best thing, all right? Sometimes what you need is to connect more with family and friends. Sometimes, I had a kid who actually probably had the best work done with the school custodian. I actually think I had little to do with that other than helping him identify that person, all right? Sometimes it's really helping people reconnect to meaningful people in their lives. And sometimes it's working with other community leaders. So it could be schools, could be faith-based leaders, could be Kiwanis, I don't know, name it. I just like to say Kiwanis, because it's kind of a funny word. But you get my drift there. Maybe it's the American Legion, I don't know. It's important to connect with that. You all should have 988 put on the back of every single bathroom stall in your buildings, because people need to know where to call. It's a national number. In Vermont, it's actually answered by staff from the Northeast Kingdom Human Services and Northwestern Counseling Services and Supports. So while it's a national number, it's a local service. And then I want to leave you with my 3 things, all right? These are sort of my 3 go-tos, which I guess would fit in that middle circle of my ecology, all right? And with this poem, I am not promoting Christianity. I want to be clear. In this poem, I'd like you to think about the sentiment of this. This is about remembering your locus of control, what it is you actually can do. And I think a lot of us get into trouble when we feel like we should be able to do more than we can, but it's outside of our control. So the poem, whatever is foreseen in joy must be lived out from day to day, vision held open in the dark by our 10,000 days of work, probably more like 1,000,000. Harvest will fill the barn, for that the hand must ache and the face must sweat. And yet no leaf or grain is filled by work of ours. The field is tilled and left to grace, that we may reap. Great work is done while we are asleep. When we work well, a Sabbath mood rests on our day and finds it good. So a lot of times what I'm trying to encourage people to do is to stop, because working harder is not going to make it better necessarily. So that's thought 1. Thought 2. This is a motto of my good friend Amy Carmola. If anybody's from St. Albans, you might know the Carmola family. Her father was a prominent doctor. She says to me, declare the day of success early and often, Cath. I'm like, I love that. It's a resilient orientation. The picture on the left is actually, I'll just share, my father would probably kill me. That's my father and my stepmother. My father is in the developing stages of dementia. He's a retired physicist. He's mentally, it's really a struggle. Physically, as strong as a horse. He's 84, he likes to bike. He gets lost on his bike. So I was down a couple weeks ago helping him access some telehealth appointments that he had. And we decided to go biking. We figured out a system that he could be on his bike and he would follow my stepmom because he loves her dearly, and I would yell, car, from the back and hope he heard me. And I wore a really bright suit. That was a success in the midst of a very difficult situation which is nothing compared to what a lot of people deal with, but it's a difficult thing to deal with, but it was a success. And we got an eclair, double success. And so the first is to stop, know your locus of control. The second is to notice your wins when they come. And the third is to listen. All right, a lot of the sentiment of what was talked throughout today is to really pay attention and listen. And some of the examples you gave were of listening. So this is Mr. Rogers, who I still think is a bit of a prophet, as quirky as he was. In times of stress, the best thing we can do for each other is to listen with our ears and our hearts, and to be assured that other questions are just as important as our answers. So, I'm not sure if you can think of a take-home action. Maybe your take-home is that it was nice to sit here and listen while you had your breakfast, and that's fine, and you got a little respite. But I would encourage you maybe to think about one question or thought that you can pursue after you leave here today, because this is big, and we all have to figure it out, because we need people to be here to take care of us. That's what I brought for you. I hope it was helpful. I'm happy to answer any questions or take any comments. All right. Thank you.